Hello, everyone. I'm Leslie, the Education and Awareness Coordinator at Dysautonomia Support Network. Over the past years, we've seen an increased awareness about dysautonomia and are working to understand dysautonomias and their coexisting conditions better. For those of you tuning in who have never heard of dysautonomia, it's a word that's used to describe disorders of the autonomic nervous system. Now, the autonomic nervous system is part of our nervous system, and it controls everything that our body does without thinking, such as controlling our heart rate, our blood pressure, digestion, temperature, breathing, and so much more. Now, dysautonomias encompass several different types, including vasovagal syncope, which is passing out, orthostatic hypotension, which involves a drop in blood pressure when you stand up, postural tachycardia syndrome, which is a disorder of orthostatic intolerance that causes an increase in your heart rate when you're upright. We have autoimmune autonomic ganglionopathy, which is an autoimmune form of dysautonomia, and there are many different other types. Now, currently, there's no cure for dysautonomia, and treatment is based on symptom management and improving quality of life. Now, most of our treatment options focus on decreasing symptoms at their end organs, and we'll talk a little bit about this type of treatment in a little bit. But tonight I'm joined by Dr. Kevin Lasko, who will share with us a different way to tackle symptoms of dysautonomia, more centrally. So we're going to explore the central control mechanisms of the autonomic nervous system and how practitioners like Dr. Lasko can intervene in a different way to help improve symptoms and quality of life. So we're excited to have him here with us. Dr. Lasko is a Board Certified Chiropractic Neurologist in Pennsylvania. He's married and has 4 children. He's a fellow of the International Academy of Chiropractic Neurology and has obtained certifications in Childhood Neurodevelopmental Disorders, Functional Imaging and Anatomy, Movement Disorders, and most recently, the treatment and diagnosis of dysautonomia in 2022. Dr. Lasko is a presenter for the Ehlers-Danlos Society Project ECHO and has significant experience in treating complex patients with Ehlers-Danlos Syndromes, dysautonomias, Chiari Malformation, Mast Cell Activation Syndromes, and more. He truly is passionate about helping improve the function and quality of life of EDS and dysautonomia patients. Now, Dr. Lasko has graciously agreed to answer questions that you send in another talk. To have your questions answered, please send them to educationteam@dysautonomiasupport.org. The email address is below, with the subject line Dr. Lasko, and we'll include them in an upcoming Dyscovery education video with him. If you have more questions of a personal nature, Dr. Lasko is willing to connect with you. You can reach him by email at lasko.hemispheres@gmail.com. Email's linked below, where he'll then set up a free 15 to 20-minute call to discuss your particular questions. So Dr. Lasko, welcome.
Thank you very much. This is an honor. Really, really is. Thank you.
Well, we're very pleased to have you. So Dr. Lasko, can you share with us your perspective and understanding of how current dysautonomia treatment protocols and options work?
Sure. From my experience, and it's been several years of kind of seeing how all this has been playing out, the treatment is really based on the peripheral organ, meaning, or like the end organ. And an example would be, if you have dysautonomia, your heart could be beating a little quicker, a little bit of tachycardia, your gut may not move as it should. And the treatment is based on how can we get the heart to slow down if it's beating too fast. And usually the default is some sort of a beta blocker, or if it's a gut problem, it could be like a Linzess or a Miralax. And they work, they will help generally get those areas to work a little bit better. But they're not addressing the central mechanisms that are actually controlling the autonomics and telling the heart to beat 100 beats a minute when it should be in the 70s, or your stomach and gut to move things along and have a bowel movement once a day. So I've kind of teased this out with various aspects of my office and doing treatment on patients and all that. and with some of the education that I had, and we're figuring out some of these central control mechanisms. And if you could activate them, you start to see a better like descending control on your heart from various aspects of your brain. And what my experience has been, a lot of patients can decrease or get off of some of the beta blockers. Their gut starts to work better. Brain fog starts to improve because you're getting to the actual core of where the problem is and not treating the end organ, which in most of the EDS patients, they don't have like a hard pathology in those areas, and you obviously have to rule all of those out first, but most EDS patients with dysautonomia or just dysautonomic patients, they've been imaged, re-imaged, poked, probed, prodded, repoked, reprobed. Nothing like hard comes up to say that's what's causing it.
So you're
And
meaning looking at like if there's a pheochromocytoma that is, pathology in that aspect that could be influencing the symptoms that the patient's experiencing.
sure. I mean, you have to get all of the true pathologic stuff looked at and taken care of first. If somebody has a brain tumor and it's causing them to have some autonomic, you have to get the brain tumor taken care of first. But most of the patients that I see, there's none of those hard pathologies that show up on like, a brain scan. And it's like, oh, that's the problem in the pituitary gland, or there's a tumor here. So minus all of that, this has to be a physiologic / neurologic control mechanism that's kind of failing.
So in other words, I saw my cardiologist and they're like, my heart is structurally fine. There's nothing wrong with my heart. And I was told it's all in my head. Now, the doctor at that time was referencing that it was a more psychosomatic situation. But he really couldn't have been more accurate in saying that the dysfunction that I'm experiencing is coming from a more central brainstem area as opposed to the actual issue with my heart, which was the symptoms that I was experiencing excessive tachycardia.
That's exactly right. He was kind of right church, wrong pew kind of idea. It minus like a valve problem or something like that in the heart. If your heart's beating 100 beats a minute when you're sitting there just watching reruns of The Office, something's telling it to beat more than what it should.
Right.
And usually that's coming from a central control mechanism that's just not functioning correctly.
Okay. So a lot of patients might ask then, if most of our treatment options are based in the periphery. So medications that I can take to decrease peripheral neuropathy, the beta blockers to decrease my heart rate, either, as you talked about, Linzess, some of the other GI stimulating meds to, help me go to the bathroom, antihistamines, cromolyn for mast cell. Are these treatments then wrong?
Oh no, I mean, it's not necessarily a right or a wrong thing. It's that they're going to affect the areas that they're going to affect. They do a good job of doing that, but they're not addressing what's actually, in my opinion, causing the heart to beat 100 beats a minute.
Mhm.
And I think that's an important concept. I'm not against any of these things. It's just I don't think a 18-year-old female should be on 21 different meds. I think we have to do a better job of figuring out where the actual system is not functioning correctly. And with looking at the autonomics, that is one system that kisses every part of your entire body. And I think that's why a lot of patients that have dysautonomia have so many different areas that are problematic with them, because I don't think this is technically an end organ problem. I think it's a system problem.
Right. So our autonomic nervous system really does impact every single organ system that we have.
from blood delivery to the tip of your head to the soles of your feet. Yep.
And so can this also be then why, oftentimes we're like each patient I found with dysautonomia is so unique. And so, you can try several different medications. Some might be effective, some might not. Some you end up having to stop because side effects of the medication end up becoming worse than, what it's intending to treat. And this causes us often to become very frustrated because, as you said, we're on 27 different medications, and still sometimes we struggle to maintain that basic homeostasis and being able to function. And
Yeah, I think this is where medical providers just in general, I think we have to do a better job of looking at a dysautonomic patient as an individual and not clump them into a protocolization, if that's a word, system, because if you really get into the nuts and bolts of this, every person that walks through that door, their central nervous system is individual to them.
Mhm.
And if you look at these things from a central, and when I say central, I mean like central nervous system, from a central problem or a central dysfunction, that's individual to each person.
Mhm.
And if it's not looked at that, you're you're kind of clumping them into a big group and say, we're going to do this because this has worked for X amount of people before. And what I find, it does work for some. There's no question. Some protocols are fine and people get better. But the ones that it doesn't really work for, or they don't get the response that they would be expecting or the doctor would be expecting, I don't think the patient's to blame for that. And going to a different place and doing the same thing over and over again, we kind of know what that definition is,
Right.
right? But if you start looking at like where in the system is the breakdown in these control mechanisms on the autonomics, it's individual to each person. And I think that's where the magic happens, when you can say this is a problem in this part of the brain or that part of the brain, or these parts aren't talking together, which is causing another part not to work. That just gets me excited. I mean, I just get excited just thinking about that.
Right. And so it really is looking at then, from my understanding of everything that you do, it's a different approach, and looking at treating dysautonomias differently. Not that you can't have these co-occurring treatment modalities. So in other words, it's not like, it's a complementary approach. People can come, they can still be on medications, but by targeting things centrally unique to each patient, then you're able to get sometimes better results, which patients can then potentially either decrease meds working with their care team as symptoms improve.
Absolutely. And we try to be in contact with the other providers that are treating the patients. And actually they're happy when you call them up and say, hey, Dr. Smith, we're doing this and this, and her heart rate's doing better, or the gut's doing better. Do you think she could decrease the beta blocker? And he was like, yeah, cut it back, see how it is. And I think that's the goal of everybody that's treating patients. It's tough to get to that point if you're not changing what the inputs are to try to decrease some of the meds.
All right, so just to kind of elaborate a little bit more. So if, say, I'm taking a beta blocker or I'm taking ivabradine or Corlinor, that is impacting my heart rate at the level of my heart. And so it's causing it to beat a little slower. But while that's impacting it there, it's still not doing anything with my sympathetic nervous system, which was driving it to go so fast initially, correct?
that I couldn't have said that better. Yeah, I mean, if the brain is a little biased toward that fight or flight side or that sympathetic side, and if it's sending messages down to your heart to beat 120 beats a minute, just kind of sitting there, and if you're taking some sort of a beta blocker, and if it decreases the heart rate down to 100, the message is still coming down, or the control mechanism from the brain is still telling it to beat at 120. It's just being kind of stonewalled there at the heart to say, I'm only going to be at 100 because the beta blockers are taking up some of the receptor sites and all that.
Right.
Yeah.
And so then with what you do as a chiropractic neurologist is you're able to then do a targeted exam, and you're able to kind of assess that central nervous system, sympathetic, parasympathetic, autonomics, all of that, and be able to kind of figure out where that dysfunction is.
Yes. I mean, that's where the kind of the magic kind of happens, if you will. And it's not like, and I see this with some patients and even with like maybe some doctors occasionally, that it's not like your parasympathetics are just shut down and they're just out to lunch and your sympathetics are just running the whole show. It's not an antagonistic marriage there. It's they have to work together, and where and more importantly, they have to work and respond to environmental stuff or anything that you're getting out in the world for an appropriate, and that's a keyword, an appropriate output, whether that's from your gut, your heart, whatever. And it's not like an on-off switch, like you're all sympathetic driven, you're all parasympathetic driven. It's just, it's which one is biased more to the other. And we need sympathetic tone. I mean, that's what keeps us alive. That's what keeps our heart beating. It keeps tone on our blood vessels. But it can get out of whack if it's firing too high and the parasympathetics are firing okay. It can get out of whack if the parasympathetics are down and the sympathetics are normal. You're still going to have a bias and not this normalcy of function that everybody wants.
Right. All right. So, Dr. Lasko, for those in our audience who might not understand even what the autonomic nervous system is, sympathetic, parasympathetic, can you kind of explain to us a little bit more about how the autonomic nervous system functions with these different branches and how that impacts our normal quote unquote function?
Sure. So autonomics, there's actually three systems, but the enteric might be another one. But basically, you have your parasympathetic and your sympathetic branches of your autonomics. And if you think of it, and there's some catchwords that I'm sure people will Google and they'll see, but your parasympathetic side is rest, digest, and repair. So that just does all the simple, like all the basic daily stuff that we do to just maintain how we function. It slows the heart rate down. It doesn't let it just go to 140 beats a minute. It helps your gut move things along. It generally vasodilates some of the peripheral arteries and veins, so you can have decent blood flow to your arms, legs, and stuff like that. It will constrict your pupils with, when you're looking at a person. So, I mean, on the flip side of that, you have your sympathetics, which is more like that fight or flight. So like if somebody cuts you off in a car while you're driving, your pupils get real big, your heart rate goes up, you might feel a little queasy in your stomach. You might say some words or do some hand gestures occasionally to the person. But I mean, it's that fight or flight, it's that protection side of your system. And I think that's like, you don't want to be in that side all the time, because that's a hard place for your system to be, because it takes more work to kind of really kick those in than it does that rest and digest and just let things kind of do whatever they're going to do.
Oh, it's definitely exhausting being more sympathetically driven. I can certainly attest to that. So that's helpful. So, in normal functioning of a quote unquote normal body, when we stand up, when we get up, when we resist gravity, we're having an interplay between sympathetic, parasympathetic.
Mhm.
And when it operates as it should, we might stand up, our heart rate might increase just a little bit because gravity is pulling blood down, but then it evens off into an irregular heart rate zone between like 60 and 100. But in those that we're seeing with autonomic dysfunction, we have this exaggerated response, and sometimes it seems like there's that higher sympathetic drive where our heart rate kind of keeps going up. We're fight or flight. We have nausea. We've got blood pooling all down in our legs, and it's very hard for us to be able to function. And that is from that high sympathetic drive, correct?
Generally, yes. I mean, if anytime you do an activity, like I'm talking, you're talking, we're increasing our sympathetic tone because we're using muscles, we're moving our hands, we're thinking. But for like patients that have an orthostatic problem, so when they stand, they get these symptoms. Yeah, that's generally, I mean, there's a bunch of different orthostatic intolerance groups, and you mentioned a couple of them earlier, but generally, yeah, if I stand up right now, my heart rate's going to go up 6, 8, 10 beats a minute because you're right, blood pools and your heart has to beat a little bit more. You have to maintain a little bit higher blood pressure to pump blood up north so your brain gets it.
Right.
But once that pump is kind of primed, your heart rate starts to come down a little bit higher than what you were when you were just sitting here, but it's going to be at a pretty much normal range throughout when you're up. Now, if you move and if you're walking and doing stuff, obviously you're using more muscles and all that, so it's going to increase. But and this is the key thing: when you stop that activity, it should come back down to about the resting state when you're upright in a
Right.
period of time. And that's where I see with a lot of patients that once that sympathetic gets going, it's off to the races. And that's where you lose some of the control mechanisms to say you don't have to go from 70 beats a minute sitting there, and when you stand it goes up to 130, 140. There's nothing saying stop to it.
So we've hit the gas pedal and we just keep on going. And then
Oh, the wheels are spinning. Yeah.
we're
Yeah.
just not able to hit that parasympathetic, that brake, and kind of bring
Yes.
stuff down.
Yeah, and it, and that's where it's kind of fun for me, because when somebody comes in like that, you really have to look at, and I touched on this a little bit, is it your parasympathetics just aren't kicking in, or are they doing what they can, but the sympathetics are just going, this is my house, I'm running the whole show. And you could tease that out with different exams, different examination techniques or findings. And that's where I think you could really target what's going on with these patients and be more specific than just say, hey, go do X protocol, where that might work, but this is really trying to like target down where is the breakdown in this system where it's not being able to control how you function when you stand.
Right. So that leads us to a great segue in looking at how do you actually evaluate those central control mechanisms?
Yeah. Oh, that's always a fun question because it's so individual to each person. But it's a neurologic exam, and it's looking at very specific things during that exam to say, does it correlate to this person's problem with dysautonomia, movement disorder, whatever it is, a high heart rate? And the way I look at it, and I think this makes a bunch of sense, is if you've ever played that game, telephone or pass it down the line,
Hmm.
okay, where I would tell you a story, you tell it to your friend, she tells it to her friend, he tells it to whatever. The story's never the end or the story's never the same at the end,
Right.
right? Somebody always kind of messes it up. And literally, that's how I kind of look at this at my examination, because we look at everything from brainstem all the way up to the prefrontal cortex, because there's a bunch of areas in between that can have an effect on how your autonomics work. So if just an example, just to kind of keep this simple, like if I tell you Billy went to the store and you tell your friend Sally went to the movies, you're the problem. You kind
Right.
of messed this story up. But if your friend says to the next one, Jimmy's playing baseball, she's the problem too, because she didn't pass the same story down the line. And that literally, that could be looking at lower brainstem, upper brainstem, cerebellum, vestibular area, midbrain, all the way up. And that's how I examine a person, and that's how I look at them, and that's how I treat them.
So I've known a few patients who have seen chiropractic neurologists, and a lot of them have said that it is by far the most thorough evaluation that they have ever had. And so that our audience can really understand, so the evaluation that you're doing, it's really just kind of either following eye movements, doing just different commands. It's nothing invasive, correct?
Correct. I mean, this is a neurologic exam um, that I've been doing for years. I just began looking at it really different, really looking at these things and saying, you know, why does that happen, and does it correlate to the person's problem? Um, and I think a lot of times with the examination that say I would do versus what you might get from somebody else is it's the interpretation of the test.
Hmm.
And I know that's like, well, what do you mean? But if somebody stands up and they're always swaying, like there's a test called Romberg's, and you stand up, you put your feet together, you can put your arms straight out or keep them down by your side, but you close your eyes and you see how does the patient sway. And you know, if somebody's always swaying center to right, center to right, center to right, technically that's not a positive test for a Romberg's, because you're supposed to take a step because you're losing your
Your
balance. But
balance.
why are they always only going to the right? And that has to kind of kick in to say, well, wait a minute, you could look at spatial stuff, you could look at cerebellar stuff, you could look at visual stuff, you could look at vestibular stuff that's going on, you could look at proprioceptive stuff. Why are they only going the one way? And does that correlate with everything else in your examination to say this area or these areas are where the failure is coming with that individual person?
Right. So, for instance, then, you could have two patients that have diagnostically the same conditions. They could have EDS, they could have POTS and have mast cell, Chiari, but they might present neurologically completely different based on the area of dysfunction within the brain,
Oh my
correct?
gosh, yes. Oh my gosh, yes. That's one thing I learned really, really quick in treating EDS, dysautonomia, all those, you know, that umbrella is I really try to look at each person coming through that door if they were like my first patient that I've ever had in my life, because I thought years back, oh, it's a dysautonomic patient. It's this, this, and this. And got my butt kicked and it wasn't. So, because there's so many different mechanisms in the brain that can give you the same or very similar effect of like a high heart rate. I mean, it could be coming from so many different areas in the brain. And if you don't kind of tease those out, you're doing a very global treatment, which should be really specific for that person that's sitting right in front of you.
Right. And so through the testing, you're able to figure out where those areas of dysfunction are. And then you're able to, I'm going to use the P word, create their own personalized protocol
I'll allow you to do that.
of, yeah, of exercises or different therapies that they're able to do to then correct that area based on the concept that the brain has neuroplasticity, correct?
Correct. Yeah. If and like with my office, when I would examine a person, get an idea of where I think I want to target some of these therapies at, do the therapies, and then retest them to see if we're getting the right response, because that's what it's about. I mean, you could do all kind of different therapies, but if you're not getting the end result that you want, why do them? So
Right.
if we do an exam, we find that maybe we need to do some balance stuff, and we do that balance thing, and their testing gets better. They have better balance. They're able to stand up more without their heart rate racing. I mean, that's a win. That then becomes one of their exercises to take home. Mhm.
And with the concept, then you're able to see direct results with the therapies, but it takes persistence with the therapies to be able to see lasting change.
Yeah, I mean, we literally pray for, a quick light switch type of thing where everything just kicks in. But most of the patients that I see, I mean, they've been sick for a while, and you can have neuroplasticity in a good way, you can have neuroplasticity in a bad way. The more that sympathetic system is just running and running and running, it gets pretty happy running the whole show. And
So
it
it's like reinforcing that bad habit over
for
and
sure,
over and over again.
yeah. So you have to get in there, and this might be getting into the weeds a little bit, but I mean, any of the therapies that I give a person, I always try to give them an objective thing to say, you got to take a break, because what you're putting in, it's not processing yet as well as what we want. You're exceeding that metabolic limit, and you have to kind of let the stew cook. You have to let that input make its connections and take a break. It's not that it's not going to work, because the system, just an example, like if we do an exercise and we see your heart rate going down, that's a great thing. But you just can't do that thing 24 hours a day, because that is going to tax you too much, because you're asking a system that hasn't been working to work really hard. It's like, I don't have enough gas in the tank to do it. So there's a gradedness, if you will, to some of the exercises that I give, but I always try to give the patient something objective to look at, to say, I need to stop that one. I might be able to move over to another one, but I need to give this area a rest to get some more oxygen and take a break and see how it would recover.
In other words, in doing the exercises, you're looking at certain parameters to monitor for that you're hitting and doing the exercise correctly, whether that's balance form, looking at heart rate, looking at certain objective parameters to know,
Mhm.
okay, now I need to stop, because for me to continue this exercise would potentially not be dangerous, but either reinforce maybe some pathways because I'm not doing it perfectly. And then you can switch to something else, but doing that more frequently over a course of time leads to longer lasting results and improvement in the patient.
Yeah, exactly. And just to simplify that, really, if you go to the gym and exercise, if you're doing bicep curls, okay, you do as many as you can. You can't do any more. Your arms are done. It doesn't mean you have to leave the gym. You could do legs, you could do squats, you can do extensions or whatever else you want to do. You just might not be able to do as many bicep curls now, because you use that system up. And I just think that's really important, because you want to practice perfect when you're doing these, and I really make that clear with a lot of the patients that I see. Like, you want to make sure, if you're doing eye exercises, you want to make sure you're on the target at all times. If your eyes jump off, what caused them to jump off? And you want to perpetuate that inappropriate pattern.
Right.
I would say no, because your system is already working in an abnormal way. Why put more wrong inputs into it?
Right. So at that point, it's pause and
Yep,
then either break, move on to something else.
exactly. Yes. Yep.
Perfect. So, it's interesting. So I've had a number of friends who have seen chiropractic neurologists, and to really truly see how the exercises correlate into the change in function is truly amazing. So heart rate going 130, 140, 150, and then either doing an eye exercise, massaging some areas, help to bring it down. How does that work?
Yeah, these are two concepts that I think personally are really important, and they're not hard to understand. They're just different. And I think with EDS dysautonomia, I think looking at these things a little bit different is actually a really good thing, because it
Mm-hmm.
gives you different windows to kind of get in there and try to help. So there's two concepts, and one is we are sensory driven, meaning, and everybody looks like, what does that mean? Like, our brains literally form and make connections with the sensory inputs that we get. And it could be wrong, it could be right. The brain could care less. Whatever you do more of, the brain's going to be, I'm good with that, let's keep doing it.
Mm-hmm.
And I use an example like, you can have blonde hair, blue eyed child born in the middle of a Nebraska cornfield, but if all that child is exposed to is Mandarin Chinese, they're going to speak Mandarin Chinese. They're
Right.
not just going to magically speak English. And that really is the way I kind of look at some of the therapies that I give patients, because if you're sensory driven and say you have some connective tissue disorder that's underlying this, you're getting some, I use the word funky, input coming in when you move,
Mm-hmm.
because the joints aren't stabilizing correctly, especially in the upper cervical spine, where you have huge beds of these proprioceptive inputs that come in to orientate you with where you are in space, with your vestibular system, with your neck, with your eyes. Huge amount of input. If that input doesn't match what the brain kind of thinks should happen, that brain can never just chill out and say, I've done this a million times, I got it, it's good. It's kind of consistent inconsistency coming in. And I think that goes for any sensory system that we have. I don't care if it's hearing, I don't care if it's vision, smell, taste, proprioception, light touch, hot, cold. If it's not perceived correctly, or if it's an abnormal input, or if you get an abnormal response, that can set up some pathways that don't fire in an appropriate way to maintain your homeostatic function as well as you can.
Mm-hmm.
I hope that
So
made sense.
So with that, then, because we're sensory driven, so, oftentimes when there's that dysfunction, especially in patients that have connective tissue disorders like Ehlers-Danlos Syndromes, that sensory input coming in is wrong. And so that's contributing to the presentation of symptoms in the patient. But on the flip side, because we are sensory driven, you stimulate the senses or the proprioceptive pathways in the right way, it can then decrease symptoms or change the symptomology in the patient as well.
Yeah, you get like, nobody is un-EDSing anyone now.
Right.
If you have it, it stinks, but you have it. And you kind of know that you're getting the feedback you're getting from the muscles and joints doesn't match what the brain expects. So that input is never correct, and the brain always kind of has to be on guard to say, wait a minute, I thought this, but you told me this. I got to make sure I'm okay with that. But if you can do sensory input from various different modalities, and it's appropriate every time that you do it, can that give the system some confidence that, hey, I'm doing this, I expected this, everything matches, let's calm down. The brain starts to actually calm down a little bit, and it creates some of these inhibitory mechanisms to shut the sympathetics down, shut the abnormal motions that you have, whether it's a tremor or like a dystonia or whatever. It can
Mhm.
shut some of those things down so they can function in a more correct manner.
Now, let's say for patients who maybe don't have Ehlers-Danlos syndrome that's contributing to autonomic dysfunction, say long COVID or concussions, is that still the same then, that with the sensory and getting wrong input in is then contributing to symptoms?
Yeah, with things like long COVID or even like a brain injury or things like that, because there's definitely enough literature out there that says brain injuries can definitely cause a dysautonomic problem. You know, in that loop, that would be a processing problem. Like you may have correct input coming in, but if that area in the brain isn't functioning, you're not getting good output, right? Because it's
Okay.
not functioning. With things like COVID or long COVID or mono or stuff like that, there's a couple ways we could look at this. Is any type of viral infection or any type of viral or even really bad bacterial problem, it really likes to target an area of the brain called the basal ganglia.
Hmm.
And that's kind of a big inhibitory mechanism where it kind of dampens down things so they do an appropriate movement when you want to move. Um, Things like COVID and, like I said, mono, that's a shotgun blast to your immune system, right? And that is going to crank your sympathetics up because it wants to kill all the little cooties that are in you,
Right.
and it's going to take that sympathetic system way up there. Can that, and I personally think it can that reset like your resting tone of your homeostatic function to a little bit more sympathetic level? I I would say yes because I've seen it. So all of those things lead to your brain or your immune system or your movement system not being able to inhibit certain aspects of your function.
Okay. So I know we had talked a little bit about that before with then the interplay of the sympathetic and the parasympathetic systems. And
Mhm.
so when we have those sympathetics that are being highly driven, we have that higher sympathetic tone. And oftentimes with that, I've heard of it with like the threshold theory, where you have like a bar graph and then, you get up to a certain point and then that's when, things kind of spill over the top and you're having more symptoms and you can get the runaway cycle of
Mhm.
everything kind of going. So normally then, when things go up, our body to a virus or anything, it will increase that sympathetic tone to allow us to fight, to allow us to take care of what is causing the dysfunction within our body. But then when we have autonomic dysfunction, it seems like we're not able to actively engage that brake in the car
Yes.
and get us back down after the infection has passed or after the threat has been driven off.
Yeah, I mean, and that could be after like a COVID, but it can also just be a resting state of your autonomic system. And I think that comes from and this is kind of the two big topics that I like to kind of, we're sensory driven, but this one is most of the problems that I see with dysautonomic problems comes from a lack of inhibition in your system. And I know that's kind of a hard concept to get your head around, but when my wife's not here, so I could say that my brain functions normally. I don't know if she would agree with that, but you know, but generally, when the brain functions well, it inhibits more things than it excites.
Okay.
And I know that's a different, that's a hard concept to get through to like lay people. And I gotta be honest, even like some doctors. And the way I would explain that is if I have a water bottle here to my right, if I get a thought process that I want to take a drink of water, things loop around in my brain. It goes to the basal ganglia and all that. And I just reach out and just pick up my water bottle. I had to inhibit everything else in my body. Like, I didn't do this, and I hope the camera, like, I didn't bring this arm up to pick it up with this hand, right? Why? I inhibited everything else. So just to move my arm out to get my water bottle, it's a complex thing, but it's more intense to inhibit everything else to keep it quiet to just pick this up. So if people with like a dystonia or even like sympathetic dominance or sympathetic like running, where is the inhibitory mechanism kicking in? Why isn't it kicking in to not let those sympathetics just run and run and run? Why is it when a dystonic person moves, they kind of writher or they might shake or get kind of like this? It's because they've lost the ability to inhibit, whether it's your autonomics or your motor center.
Right.
It's kind of a hard concept to get, but in the brain, there are a ton of these areas that you have to excite to get the inhibitory mechanism to kick in. So it's kind of almost like adding a positive and a negative, and that always confused me when I was younger.
But then because of how you're trained, then you're able to, with that neurological examination, determine that almost that precise area of dysfunction, making sense within the patient's, kind of holistic presentation. And then because you know where that dysfunction is, you can then prescribe the different exercises and therapies in order to be able to either like start that inhibition process, right?
Correct. And that's exactly, I mean, that is exactly what we do. We look at the patient, where in that telephone chain in that game, who isn't passing it down the line correctly.
Mm-hmm.
We need to talk to them. And like I said, that could be brainstem, that could be cerebellum, it could be a vestibular problem, could be a midbrain, all the way up to the prefrontal cortex. And you just have to kind of tease that out during the examination to say, if we do, say, a balance test, are we getting the right response? And if it lowers the heart rate, we know we're getting more inhibitory mechanisms to shut that sympathetic side down. And that's a better functioning person.
Right. And on the flip side, then, if you do an exercise and then all of a sudden heart rate's going up, things are being more sympathetically driven, that's probably not the response that you want. So, not going to work for the patient.
Yeah, I screwed up then. But hey, you do, yeah, I mean, if you do something and you don't get the right response, you don't want to keep hitting your thumb with the hammer, right? You want to try to hit the nail. But that's pretty cool, because then we could then develop like almost a daily activity thing, like the P word, like a daily activity program. I didn't use protocol, a daily activity program for the patient to say, hey, I know you've been doing this, but this could have really been activating that sympathetic system. Can you try this instead of the thing that was causing the problem? And that could be from, how do you stand up? How do you get out of bed in the morning? How do you brush your teeth? How do you walk? Do you walk? I mean, it's just a ton of things that we can do to try not to give that bad input into the system, so it's not comfortable, so it doesn't work correctly.
Right. And so it's even just the little mundane things changed in a slightly different way that can help the patient with improving quality of life and improving symptoms.
You would be, and I know you said you knew people, but I mean, you would be surprised with some of the simplest things that could be done that can allow somebody to stand up without their heart rate going 60 beats higher. It's not everybody, but it's the potential's there, depending on that person's I call it central integrative state. Like, how do they process all this input coming in, and do they get the right output at the right time?
Right.
Mhm.
So, for instance, my friend had a certain way of being able to get up from laying down or from sitting, and it involved kind of priming their system in order to be able to help them with standing up so heart rate didn't go out of control.
Yeah, yeah. And I mean, there's others with, yeah, just standing up, getting out of bed. Some people, if they always turn to one side and they're like, oh my gosh, who turned the lights out? Well, can you do some things that might help you when you turn to the right? And again, we examine, we treat, and we re-examine. Did that help? If it did, you just got another exercise to take home.
Right.
Mhm.
And I know it's been amazing to see the result with my friends with going from heart rate kind of crazy all the time to now having heart rates within the quote unquote normal range, being able to shower without dying, which is definitely huge, and not having, that heart rate run away, but having tools in the toolbox, as
Mhm.
they said, to kind of be able to help them manage when the sympathetics just kind of want to go out of whack.
Yeah, yeah, it's nice, and I think the best thing about this is your toolbox, your friend's toolbox, Susie that's coming in next week, Sally that's the week, John that's the third week. Everybody's toolbox is going to be different,
Mhm.
and that's the nice thing, because you we could really, like, target certain areas of the brain that are individual to you that aren't functioning correctly, target the therapies to that or those areas, and that becomes your little toolbox that you carry around and you do when you're at Chili's or Texas Roadhouse or at the movies or just sitting around and you have to get up and use the bathroom. You could pull those out and not have to have that sympathetic system just go through the roof. Mhm.
And so, it's one of those things. It's not a cure for dysautonomia. It's not that, as you said earlier, you all of a sudden don't have EDS, but
Right.
it's just giving you those tools that will help you based on your personal presentation. And
Yeah.
that's, we have the zebra, especially for those with EDS, and each zebra is so unique. Their stripe patterns are all different. So while there can be some commonalities, you're still going to have that unique presentation of what's causing that dysfunction. So, by having a personalized protocol or program, you're able to then help improve your quality of life, help decrease symptoms, and really be able to learn how to navigate life with all of its ups and downs that challenge the autonomic nervous system.
Yeah, I agree 110%. And as you kind of taking a step back, like, as you start to give better and more correct input into that system, and as you begin to stand, like, just an example, if you stand up and your heart rate doesn't go up 50 beats a minute, and all of a sudden it might only go up 25 or 30, and then it might only go up 20, and then it might only go up 15, because I've seen that. And that's developing, that's learning. Your body is literally learning how to stand up and respond in an appropriate manner based on learning not to just let those sympathetics run. And
Right.
that's neuroplastic change. If you can keep firing that system, get the correct response, that system's going to change to be more correct, or as correct as it can be based on that individual person.
Thank you for joining us for part one of Understanding Central Control Mechanisms of the Autonomic Nervous System, a conversation with Dr. Kevin Lasko. Stay tuned for part two, where we explore more of the central control mechanisms, including an in-depth look at the baroreflex. As mentioned earlier, if you have any questions for Dr. Lasko, please send them to educationteam@dysautonomiasupport.org with the subject line Dr. Lasko.